Well, hello and welcome, or welcome back if you've been following this series, which concerns autism spectrum disorder in three dimensions. My name is James Coplan, MD, and I will be your guide to this material. If this is your first time visiting this blog series, I suggest that you go back and pick up at the beginning so you'll have some continuity. And if you've been following along, thank you for sticking with me. I will try to keep my posts a little shorter than they have been up until now. Somehow they always creep and get a little longer than I mean them to, but today I'm really going to try to hold the line. So what we're going to do today is introduce the topic of overall cognitive development with the eventual goal of talking about something that nobody really likes to talk about or wants to talk about, and that's the subject of intellectual disability. There's nothing in the definition of autism about intellectual disability. People on the autistic spectrum can have any degree of cognitive development from genius IQ to profound ID. And that's the whole point. And unfortunately, this is such a fraught topic that a lot of people have a hard time discussing it. But in order for you to be informed parents or informed care providers, you need to know the relationship between ASD and intellectual development, where they overlap, where they differ, and most importantly, the impact of intellectual development on prognosis for people with ASD. So today, first we're going to lay the groundwork and we're going to talk about normal cognitive development kind of in a nutshell. People spend their entire careers, their entire university level schools that are dedicated to nothing but normal child development. So we can't possibly do this justice in 20 minutes, but I'm going to provide you with an ultra distilled, boiled down essence, which is just an introduction to the whole body of knowledge. And then there are ways that you can expand your knowledge by reading, going to my website, www.drcoplan.com, or other readings. But here we're just going to launch into the briefest of introductions to normal cognitive development as the groundwork for what follows next week, which will be a discussion of intellectual disability. So this is where we left off last week. You may remember this graphic, and the ice represents the degree of ASD that the individual has. And it can be anything from just a little smidgen, like a little chip of ice, to a very huge and prominent level of ASD represented here by an iceberg. And the iceberg is rather improbably floating in a little lagoon somewhere in the tropics, and that's the point of this graphic, because the water temperature is analogous to the IQ. So IQ is over here, ASD is over here. You can have any size of chunk of ice from tiny to huge, and it can be floating, I showed here very optimistically, in tropical water, or this chunk of ice could be floating in the Arctic, where the water temperature is still fairly cold, global warming notwithstanding. And this is the model that I want you to hold in mind as we begin to unpack what we mean by IQ. And first, as I said, we're going to talk about normal child development. And we begin our discussion of normal child development with this graph, which is based on the work of the late Arnold Giselle, who was a clinical psychologist and developmental pediatrician who worked and practiced at the Yale Child Study Center. And he described what he termed streams of development. And we have here a schematic representation of abilities increasing over age. And the streams of development that Giselle identified included gross motor, fine motor adaptive, personal social, and then play is something that I'm not sure he had as a field of development. I may have added that myself. I'll have to go back and double check. And then language. And one of Giselle's contributions, besides conceptualizing this developmental model, was to state that a child's development may be normal, delayed, or atypical. I'm not sure, again, if he used the word atypical. He may have used a different word, but may be normal or, if you will, abnormal in any one area independently of the child's development in the other areas. In terms of gross motor, he described, as other people have before and subsequently, the evolution of gross motor control, starting with things like head control at 2 to 3 months, rolling over at 4 to 5 months, sitting at 6 to 7 months, crawling on hands and knees at 9 months, pulling to standing and cruising around furniture, independent walking, going up and down stairs, and pedaling a tricycle. And then milestones continue beyond there, things like riding a two-wheel bike. But these are some of the things that emerge during the infancy and toddler and preschool years. In terms of fine motor and adaptive, and you'll see there's a lot of overlap between fine motor and adaptive. Things like midline hand play. This is where a baby is lying on its back and literally putting its two hands together and playing with its ability to manipulate its hands in front of its visual field. Reaching, palm or grasp, it's what I call flypaper palms, where a 6-month-old may pick up an object and it's almost like they have flypaper or Velcro in their palms, and they sometimes have a hard time releasing an object, but they eventually become able to do that and transfer objects hand to hand. Thumb and forefinger grasp, index finger exploration. If you give a 10 to 12-month-old some kind of small object, they'll run their index finger around the inside of the object to explore whatever it is that you've given them. Tool use around a year of age, and we're not talking about jackhammers or things like that. We're talking about a spoon, which is a tool, and a crayon, which is a tool. And then language. And again, there are people who have made their entire careers, and there are university departments that are solely dedicated to the study of language or language development in infants. Now, this is a shameless plug. This is the Early Language Milestone Scale, which I published back in 1980. Oh my goodness, a long time ago. 1983, it says in the fine print at the bottom. And what this intends to show is a thumbnail of language development from birth to 3, so that when physicians are assessing a child in the office, they have something to refer to. And the first area on here is what I called auditory expressive language. And if we drill down a little bit, there are what are called pre-linguistic milestones. In other words, these are not abstract linguistic ideas that a child is putting forth verbally. Rather, they are sounds, cooing, vocalizing back and forth with a care provider, laughing, the raspberry or Bronx cheer, that kind of a sound, and then monosyllabic babbling, ma, ba, da, polysyllabic babbling, things like la, 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 ma, 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 na, 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 da, 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 da. And these follow a highly predictable sequence during the first 7 to 9 months of life. And then one day, by accident, the child truncates the utterance mama. Instead of mama, mama, ma, the child goes mama or dada, and the parents go wild, and the child is initially afraid, what did I do wrong? But then the child gets reinforced and eventually begins to make those sounds in association with the parents. And then the little light bulb goes on over their head, and they realize that not only does the sound mama or dada call forth that parent and elicit parental approval, that it actually represents that individual. It stands for that person. And from there, the child goes on to develop single words other than mama or dada, and with a rapidly expanding vocabulary. And then they begin to use words to tell what they want. They make two-word phrases. Vocabulary continues to grow. Length of utterance grows. Complexity grows. Clarity of speech improves. And these are all things that we're not going to have time to go into in detail. But suffice it to say that the detail is there if you want to go and read about it. And then on the receptive side of things, also during the first 6 to 9 months of life, a child engages in pre-linguistic, in other words, pre-symbolic auditory receptive behaviors like alerting to voice, turning to voice. Now, does the child recognize sounds? This is subjective on the part of the parent, but you ask the parent of a 4-month-old, do you think your child recognizes your voice or any other particular sound? And notice, when the children are newborns, no parents say yes, but by the time the child is maybe 6 weeks old, they think so, some of them, and then by 3 months of age, parents are really clear that the child is reacting in some discriminating way, either to them or to a sibling or to some other sound in the environment. Children learn to turn to sounds. They inhibit to the command no. They'll stop transiently and then they may gleefully go right on. And then you also get to a transition point here around 9 months of age where the child begins to engage in truly symbolic behavior. If you give the child a command, this says one-step command without a gesture. So with a 7 to 9 month old, you might say, give it to me and put your hand out. But at 9 months of age, you don't have to put your hand out anymore. You can just say, give it to me, and the child will understand and give you the object. And then children begin pointing to body parts on command. They follow other types of commands, two-step commands. They point to named objects. And again, the complexity of the commands they can follow grows by leaps and bounds. And then finally, and I'm rather pleased that I included this, we have a whole section on visual language. And this includes, in the earliest stages, things like smiling. And again, does your child recognize your face? And this is purely subjective. This is by parental report. H and O means by history or observation. There's no way you can really test this, or there's no easy way in the office to test it. In a research setup, you probably could. But at birth, no parent thinks their child recognizes them. But by 6 to 8 weeks of age, 25% of parents say yes. And by 3 months of age, better than 90% of parents say, yeah, I think my child recognizes me. And if they don't say yes, then there's something very different, either about that parent-child relationship or about the child. And there's a researcher by the name of Rebecca Landa, Landa, who has made videotapes of newborns who go on to get a diagnosis of autism. You can look up her work, and I've seen the videos of 3-month-olds. These are the younger siblings of children already identified with autism. She got these parents to participate, to enroll their next born child in her prospective videotaping, knowing that maybe 10% of these children would also be on the spectrum. So she has videos from the earliest of infancy, and you can see how these visual responses are blunted from the very beginning. By about 7 to 9 months of age, babies are beginning to initiate or imitate and then initiate gesture games. And then this is where following a command with a parental gesture and then pointing to desired objects around a year of age. And one thing that's very striking is that if you compare the age at which children produce their first single word other than mama or dada with the age at which they begin pointing to desired objects, the 90th percentile mark for those two skills is virtually the same, within days of one another, because they represent the same cognitive or linguistic ability, the ability to signify an object symbolically. A 9-month-old may be sitting at the table and crying and reaching for something, but a 12-month-old can point to the object and then look at you and then look back at the object. And that's the whole thing about joint attention. And they know that you know to look at the object they're pointing at, and that you're going to know that they want it. So this gets into things like joint attention, the theory of mind. but at the simplest level, it's index finger pointing to desired objects. And then there's problem solving. And this has a lot of manifestations. Some of the most evident are, first of all, object permanence. And we have a hilarious video of my now 45-year-old daughter at a year of age sitting in her high chair, and she has a little dish of peas. And she doesn't know that the camera is on a tripod across the room. And she takes a pea and she looks around to make sure we're not watching, and she throws it over the side, and then she looks over the side to see where it went. Yep, there it is down there. And then she takes another one and she throws it, and another one and another one. And it's clear that she's making mischief, and she knows she's making mischief, and she's just enjoying herself tremendously. And that's just a wonderful point in a child's development. When they have that object permanence, they know that even though they can't see it in the moment, it's still down there. Tool use, again, I mentioned, the use of a spoon or the use of a crayon. You ask the mother of a 9-month-old, would you give your child a crayon? They'll say, heck no. He'd chew on it. You ask the mother of a 14-month-old, would you give your child a crayon? They're just equally likely to say no, but the answer is different, because now they'll say he'd write on the walls with it. So the child has graduated from using the crayon as a teething object to using it as a tool. Then there's cause and effect. If this, then that. You may have held your child in your arms and walked up to a light switch on the wall, and you flick the light switch, and then the light goes on and off, and the child sees it, and the child does the same thing. Now, back in the day, back in the last millennium, when I was a child and when my children were young, there were toys like these. These were made by the Fisher-Price company. These are actually for sale on eBay. They're collectibles now, but you can see one is the cow and the frog and the tugboat. And instead of having a string, they're all on wheels. You see there are little wheels down there, wheels there. I think the frog hops. I don't think he rolls. But instead of a string, there's this squeeze bulb and 3-foot length of plastic, yellow plastic tubing. So the child at about 14 months of age is practicing his or her newfound skill of walking, and they're pulling this toy behind them. But what else are they doing? What else are they doing? They're squeezing the little bulb, and the little smokestack goes up and down and makes a toot, or the frog hops and makes a ribbit, the cow makes a moo. So the child is practicing cause and effect, cause and effect, cause and effect, over and over and over again. And it's simply more of the same from this to asking for the keys to the car at 16, or doing brain surgery. It's just cause and effect. There are also things like this, of building progressively more complex structures out of blocks, or reproducing progressively more complex drawings on imitation of the examiner. Here's a photograph of my developmental kit bag. I'm not a psychologist, but I'm a developmental pediatrician, and I would use these types of tasks as one way of screening. And you can see here there's a book which has to do with things like picture naming or pointing to name pictures, and the Elm scale is in there, and then some of these problem-solving tasks as a way of getting a handle on a child's cognitive development during the preschool years. Adaptive skills. Adaptive skills are self-care skills. In rehab terminology, these would be ADL, activity of daily living skills. Self-feeding, self-dressing, self-grooming, and again, we see things like finger feeding, the use of a cup. Here's the spoon again. Self-dressing, unbuttoning, buttoning up, doing zippers and snaps, shoe tying, toilet training. These are all self-care skills. And then play. And this is really the missing milestone. And I don't think Giselle had play in his list. Now here we're using terminology from another contributor to the field, John Piaget, Piaget, and he talked about the sensory motor stage, where children's interaction with the world is dominated by learning mastery over their body and by the physical sensations of things. So midline hand play, we mentioned banging and mouthing. That's a typical schema or interactive pattern of a 7 to 9 month old child. They'll bang things, they'll mouth them. Casting, throwing things over the side. We talked about that in connection with object permanence. Here again is tools and cause and effect, and these keep cropping up. They're a fine motor skill, they're a play skill, they're a cognitive skill, they're a problem-solving skill. They really cover a lot of different areas. And you can do a thought experiment of envisioning a child with a physical disability like cerebral palsy who may know what a crayon is for, but is physically unable to do it because of motoric impairment, in contrast to a child with cognitive delay who may be physically perfectly capable of picking up a spoon but doesn't understand what it's for or how to use it from a cognitive standpoint. Then again, using Piaget terminology, we're not going to trouble ourselves with those stage names, but the next kind of play is imitative play, and then make-believe play. Make-believe play really comes in full bore around 3 years of age, along with verbal humor, verbal make-believe, and fibbing. If you've ever been reading with a 2-year-old and there's a picture of a horse in the book, and you say, "Look at the cow," the child will look up at you and say, "No, that's a horse. You're silly." And they know you're making believe on purpose for fun. And then by age 3, they're fully into all kinds of make-believe play. And as I said, fibbing is a skill that they're practicing avidly up until they learn that they shouldn't do it anymore. Then you move on to rule-based play. And around 4 years of age, children discover that life has rules, and they go around applying rules to everything. I remember when one of my children was 4 and she was sitting in the back seat of the car, and I was driving, and she piped up, "Daddy, I thought you said that yellow light meant slow down and stop, but you didn't stop when the light was yellow. You sped up." Because she was learning to apply rules to everything. And this is when games like Uno and Candyland, which I've played a million times, are so popular because kids are practicing their skill du jour, their skill that comes along with each new stage of development. And so they're practicing rule-based behaviors. And then again, Piaget's term formal operations. This involves games that have multiple possible outcomes and multiple strategies, things like checkers, chess, bridge, poker, which involve asking, well, what if this, what if that, which is a whole different cognitive dimension than things like Candyland or Uno, where you know exactly what you're supposed to do. And here's a graphic that is going to take a little bit of time to explain, so let's take a few minutes on this, and this is the last slide for today's blog post, so just stick with me. The end is almost here. What I have done here is to create kind of a horizontal bar graph or a chart, and you see the lower half it says motor, and the upper half it says cognitive, and then over here it says percent, and the heading says relative contribution of motor and cognitive ability to different streams of development. Okay, so on the left we have things that require relatively less of a cognitive contribution. In other words, they're relatively purely motoric in nature with very little cognitive requirement at all. And these may be normal in children with intellectual disability. In fact, the majority of children with intellectual disability walk at the normal age, even though they may have significant cognitive delay. And we see over here gross motor milestones like sitting, standing, and walking are commonly normal in kids with ID. Now, it's still true that if you said to me, I have an 18-month-old who's not walking, is it a problem? In my mind, I would still say to myself, if this is something problematic, if this is not simply a variation of normal, then the most likely thing it is to be is intellectual disability, not cerebral palsy, which is a physical disability. But on the flip side of the coin, it's still true that the majority of children with ID still walk at the normal age. On the right-hand side of the graph, we have things that have an increasing cognitive contribution and relatively less in the way of a motor component, because you see over here, these things are going to be purely cognitive. And what we see kind of in the middle, 50-50, motor and cognitive, are things like the fine motor and adaptive skills. That's why things like using the spoon and the crayon turned up under fine motor, they turned up under adaptive, they turned up under problem solving, because you need both the physical wherewithal to move your hands as required, as well as the cognitive ability to understand what it's all about and why. Speech also is a highly refined motor milestone. Play, even more so, does that involve a cognitive input. And then all the way over to the right is receptive language. And there have been cases, and I've had patients like this, who may be totally physically incapacitated, but they still have language comprehension. And if they have any kind of motor output at all, like eye blinking or eye gaze, they can be provided with some sort of prosthetic communication device so that they can communicate with whatever motor outputs they may have. So over here are things that are very heavily tilted in the direction of a cognitive contribution, with receptive language being purely or almost purely cognitive. I still remember I had a maybe 10, 11-year-old boy as a patient when I was in my training back in the 1970s, and this lad, he had something called athetoid cerebral palsy. He had zero control over his body. He was unable to speak. But by the nature of the condition, the one thing that was still preserved was eye gaze. And I brought a vocabulary test to the bedside. This kid was 10 years old. Everybody had treated him as if he had no cognitive ability at all. He was nonverbal. He was totally physically dependent. But his nurse's aide had said to me, "Dr. Coplan, Joey is brighter than anybody thinks, but nobody will listen to me." So I listened to her. And I took this vocabulary test to the bedside. And it was a picture vocabulary test where you had to point to one picture out of 4 on each page. Well, I took the book of test pages down to the basement at Johns Hopkins to the only enlarging Xerox machine that was on the premises. This was like 1975. This was super science fiction. And I enlarged all the pages so they were 2 feet by 18 inches instead of 9 by 12 inches in the little book. And I brought the pages to the bedside and I said, "Joey, look at. And with his eye gaze, he was able to make the correct selection page after page. And this kid had a normal receptive vocabulary for age. He had normal cognitive abilities locked inside of that body. And we were able to fit him at that time with a prosthetic wheelchair. Nowadays, the technology is so much more advanced. But believe me when I say that receptive language does not require any kind of motor component, as opposed to over here walking. I've had children as patients with profound intellectual disability who got up and walked at a year of age, even though their cognitive abilities were no better than a neonatal level. So this model is something I want you to hold in mind, along with the iceberg model, because these items on the right are the ones that are more likely to be delayed in intellectual disability, and that's going to be the subject for our next post next week. Well, there you have it. I'm afraid, in spite of my best intentions, this also has run, about not quite half an hour. Forgive me, and thank you for sticking with me. I hope this information has been useful to you. Next week, we're going to integrate this information into our discussion of intellectual disability. And from there, we're going to show how the relationship between ASD and cognitive ability plays out and how that impacts prognosis. So thanks again for stopping by, and I'll see you next week.